about a case in our ICU in Susmet. It is very unlucky case. However, this patient survived. A 56 years old Malay lady with underlying well-controlled diabetes mellitus with no end organ complication presented to emergency department with 4 days of fever, lethargy, reduced oral intake, diarrhea, and left iliac fossa pain. 1 week prior to the presentation, patient had history of bathing in a river water at Kelantan. What are your differential diagnosis? Anyone?
Leptospirosis.
Correct. Other than that? Anyone?
Myelodisis.
Correct. Other than that? Lagi guys, nak exam ni. Don't focus on the medical causes. You can also say about the surgical causes. You must open up yourself. What are the other differential diagnosis? What strikes you if you say in Kelantan?
Typhoid.
Typhoid, correct. And then lagi apa lagi nak cakap? You can always say EGE, right? You can always say about diverticulitis, about left iliac fossa pain. Okay, so she was clinically shocked upon presentation with BP 82/50, MAP 55, pulse rate 123, with SpO2 95% under room air. Her initial laboratory results were notable of hemoglobin 12.9 gram per liter, white blood cell of 13 to the power times 109 per liter, platelet count of 258. She also developed acute kidney injury, transaminitis, hyperlactinemia, and also with a lactate of 4 millimole per liter after fluid resuscitation 30 mils per kilo. On the same day, she was admitted to ICU for septic shock to rule out causes. Her arterial blood gas show worsening metabolic acidosis with increase of lactate to 4.9 millimole per liter. Later on in the ICU, she was intubated for severe metabolic acidosis and multi-organ failure. Post-intubation, vasopressin infusion was added. On top of that, she was put on infusion noradrenaline, and a diagnosis of septic shock secondary to possible intra-abdominal sepsis with multi-organ involvement, respiratory failure, and AKI with metabolic acidosis was made. So differentials, myelodisis, leptospirosis, bowel ischemia, bowel perforation, typhoid, diverticulitis was made. We proceed with the CECT scan of abdomen, reveal a thickened acalculous gallbladder with gallbladder wall with the presence of pericholecystic fluid, suggestive of acute acalculous cholecystitis. Initially, she was put on the broad spectrum antibiotic tazocine, piperacillin, and tazobactam. Later on, she was escalated into the coverage of meropenem and vancomycin. You can see over here, this is the gallbladder. There is no stone over here with thickened gallbladder wall, and there is a pericholecystic fluid collection. So this is a case of acute acalculous cholecystitis, very rare disease, but very dangerous in terms of mortality and morbidity. The disease itself can progress into gangrenous cholecystitis or perforated gallbladder and cause severe intra-abdominal sepsis and with high mortality. So this patient has came to you with a septic shock with ACI. What is the mortality for this patient if left untreated? Anyone knows? Anyone? Boleh teka dia tembak. Berapa persen mortality rate?
50%.
Almost there. Any other taker?
70%.
Correct, 70%. Siapa tu? Siapa tadi?
Say
Okay, very good. So we initiate CVVH HDF. We specialize hemophilter. This CVVH HDF is a hemodialysis, continuous, with a slow, meaning with a slow pulling of the blood, having the Osiris filter. This is a filter whereby that has a specialized antitoxin and also cytokine absorption filter. So in this way, the inflammatory mediators will be pulled out from the patient, and after the initiation of Osiris filter, we manage to reduce noradrenaline infusion gradually and able to cease on day 3 of ICU admission. Meanwhile, the vasopressin infusion was put off after 67 hours of ICU admission. And also, we note the lactate level significantly reduced after the initiation of Osiris. And over 10 days of ICU stay, her SOFA score dropped 50% in comparison to first day. And we discontinue of CVHDF after 67 hours due to marked resolution of her metabolic cirrhosis. So this is the first graph over the left side, the graph of the noradrenaline and vasopressin. Initially, there are the noradrenaline is very high, 0.4 microgram per kilogram per minute, and we able to taper down off and off after about 48 hours, and vasopressin able to off also after 67 hours. The serum lactate also reducing initially after the initiation of the Osiris filter. Okay. So when you talk about an infection, does an infection is a sepsis? And any thoughts on this? Let's say a patient came with a leg abscess. Do you call that a sepsis? Ashraf, Ashraf,
Ya, Doctor.
apa jawapan?
No,
Why?
because it does not fulfill the criteria for sepsis.
So what is definition of sepsis? Anyone else? Intan Nur Kamalia? What is definition of sepsis? I think you guys right during 4th year. Intan ada ke tak?
Ada, Doktor. Sepsis it's is an extreme response to infection.
Apalah Intan. Kau baliklah. Alah tu, macam mana awak nak pergi exam ni? Kena baca lagi ni. So sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. This is definition. You cannot tembak. You cannot reka-reka. This is full definition of sepsis. It is life-threatening organ dysfunction caused by dysregulated host response to infection, whereby the septic shock is a subset of sepsis in which the underlying circulatory and cellular metabolic abnormalities are profound enough to substantially increase the mortality. So septic shock has two clinical criteria. So number one, it must present both persistent hypotension requiring vasopressor to maintain MAP more than 65, and also the lactate greater than 2 millimole per liter. So like I mentioned in this slide, it is not a severe form of infection. It is life-threatening organ dysfunction. Previously, when we talk about the definition of sepsis, it must present with two components of SIRS plus infection. However, what happens if we talk about SIRS only? SIRS can also present in hypercatabolic state of a disease, for example, cancer, for example, thyroid storm, or for example, pheochromocytoma and other hormonal issue. Hence, the definition of from taking from SIRS is not correct. That's why the sepsis is taken from the life-threatening organ dysfunction caused by dysregulated host response. When a person succumb to an infection, the infection become localized. Our body tends to overact with it with increment of our inflammatory mediators. These inflammatory mediators consisted of your interleukins, cytokines, your TNF alpha, and also complement system. This, when there is overwhelm of infection, there will be markedly increase of these inflammatory mediators and causing harm more than helpful to the body of a person. Hence, causing dysregulated host response to the infection and cause life-threatening organ dysfunction. There is no more a statement saying there is a severe sepsis. There is no severe sepsis. The severe form of sepsis is the septic shock. So septic shock, you must remember definition is full like this, is subset of sepsis in which the underlying secretory and cellular metabolic abnormalities are profound enough to substantially increase the mortality. When we talk about sepsis alone, the mortality is around 20%. Septic shock, the mortality is around 40%. When a septic shock plus AKI, the mortality is 70%. This is the sepsis bundle in 2016, whereby the initial bundle is to measure the lactate first, and if the lactate more than 2 millimole per liter, to remeasure later, obtain the blood culture before the obtaining the antibiotics, administer broad spectrum antibiotics, begin rapid administration of the fluid, 30 ml per kilo crystalloid, for hypotension or lactate more than 4 millimole per liter, and apply vasopressor if patient hypotensive to maintain mean arterial pressure of more than 65 millimeter mercury. So why lactate? So the overview of it, it is a product of anaerobic glycolysis which reflects type A, in which there is impairment of oxygen delivery, or type B, altered metabolism causes. 50% will be eliminated by the Cori cycle, and the accumulation of it will lead to lactic acidosis. So the normal range is 0.6 to 1.8 millimole per liter. Hyperlactinemia is a level 2 to 5 millimole per liter. Severe lactic acidosis when the range is more than 5 millimole per liter. High mortality in patient with sepsis in which it lactate more than 8 millimole per liter. So do you guys still remember about this? This is the glycolysis, whereby there's a breakdown from the glucose into the pyruvate before entering the Krebs cycles. As you can see over here, when there is in unavailability of the oxygen, the pyruvate will go to the left side, go into the lactate production, and the total ATP production from the lactate is 2. So after that, the pyruvate will change into acetyl-CoA before going into the Krebs cycle to produce a total of 38 ATPs in aerobic glycolysis. So now I mentioned to you there is a normal value of lactate. Why is that? So siapa nama Ni year 4 ke? Khairun Nadia. Kenapa ada normal value of lactate? Why there is a normal value of lactate? Khairun Nadia, are you there? Khairun Nadia, are you there?
Yes, doctor.
why there is a normal value of lactate? Since lactate is anaerobic metabolism, right? I tell you before why there is a normal value of lactate. Anyone to help? Nur Akilah?
Because it indicates sufficient oxygen at cellular level.
Sorry again, come again. Tak dengar lah.
It indicates sufficient oxygen at cellular level.
It end stage, maksud awak? End stage.
Sufficient oxygen at
Oh,
cellular
okay.
level.
Okay. Good try. However, at rest, there are tissues that produce excess lactate for the use of its energy. For example, skin 25%, red blood cell 20%, brain 20%, muscle 25%, and gut 10%. This is why there is a normal value of lactate in our body. Okay. So when we talk about the hyperlactemia, there is this is based on the what classification are we talking? Cohen classification, COHEN, Cohen classification. So the Cohen classification for hyperlactemia will be divided into type A and type B. Type A is tissue hypoperfusion, example shock, and then type B will be divided into B1 is associated with underlying disease, example liver disease, malignancy, severe hypophosphatemia, HIV. Type 2 B2 is medication, example aspirin, salicylates, anti-TB. B3 is inborn error metabolism. Okay. So does hyperlactemia is because of reduced perfusion in shock? What do you guys think? Is it falls under type A or other confounding factor? What do you guys think of the hyperlactemia?
I think both of it,
So both, why? Why both?
because it can be due to underlying condition or it can be due to hypoperfusion due to shock.
Okay, hyperfusion, so it's under one. So because of the underlying disease, what disease are you talking about?
Infection and multi-organ failure.
Okay. Kalau organ apa yang akan cause high lactate? Di metabolism?
Liver.
Correct, liver. Okay. So yang paling penting, several studies have shown an increase of lactate without deficiency in oxygen delivery. Instead, there is a connection has been found between epinephrine stimulation and elevated lactate. So what happened? Epinephrine or adrenaline binds to receptor which stimulate CAMP production, leading to activation of sarcolemma sodium potassium ATPase. This pump is fueled by the glycolytic pathway, therefore creating a direct link between ATPase pump and lactate production. Meaning here, the adrenaline binds to this receptor and this receptor producing more lactate production. Okay. Other than that, there is also endogenous catecholamine release. This is also adrenaline. Circulatory failure due to hypoxia and hypotension. There is also cytopathic hypoxia in which there will be widespread microvascular shunting and also mitochondrial failure causing high lactate. Inhibition of pyruvate dehydrogenase by endotoxin. So the pyruvate cannot be changed into the acetyl-CoA to go into the Krebs cycle. There is also coexisting liver disease that I mentioned before. Okay, I hope you guys understand about the lactate, why there is a hyperlactatemia in the sepsis and the importance of the hyperlactatemia. So it is a marker for showing that severe sepsis in a severe form of sepsis, and also to check about the mortality of the patient in a septic shock. Okay, so how about the fluid resuscitation? We need a coordinate team approach in appropriate equipped staff resuscitation. So we manage based on airway, breathing, circulation. As I mentioned before, how do you manage a patient if you want to answer in exam? I will manage based on airway, breathing, circulation. D is what? Disability is E is exposure. Okay, so airway, maintaining the airway so the patient can breathe spontaneously. Breathing, check for breathing pattern. If breathing inadequate, help the patient by giving the oxygen, or intubate the patient with maintaining SpO2 more than 95%. C, circulation, insert the IV line, maintain MAP more than 65, and giving fluid. Okay, and then attach monitoring, heart rate, ECG, and NLP, monitor respiratory rate and SpO2 and large bore valvular. So when we talk about the septic shock, this most severe expression of circulatory dysfunction of the sepsis, it is unintended consequence of the release of vasoactive mediators, which purpose to improve the metabolic autoregulation, in which the process that matches the oxygen availability to the changing of tissue oxygen needs. Because why? In sepsis, there is catabolic state of a person whereby there is a need of higher oxygen. So so the body tends to release the vasoactive mediators to cause vasodilation, hence to produce for the heart to pump more into the peripheral vasculature. This is by producing nitrous oxide and prostacyclin. Other than that, septic shock also can be result from reduction of the vasopressin. So vasopressin is causing vasoconstriction. So reduction of vasopressin causes vasodilation, and also redistribution of fluid, in which when there is an increase of inflammatory mediators, the fluid intravascularly will be shifted to other place, example to the lung, to the peripheral tissue, causing edema, and so acute pulmonary edema. So before I'm going further telling you about the fluid, I hope you guys know types of shock. So the way of saying the type of shock is divided into hypovolemic, cardiogenic, distributive, and obstructive. So a septic shock falls under distributive, whereby there is a reduction of systemic vascular resistance. SVR over here is systemic vascular resistance. This is caused by, like I mentioned before, increase of vasomediators, reduction of the vasopressin, also distribution of fluid. Other than that, other causes of distributive shock can be anaphylaxis, neurogenic shock, drug and toxin, and also Addisonian crisis. Okay, so what happened in the hypovolemic shock? There will be reduction of volume, right? So reduction of volume, so there will be reduced. This one is preload, reduced preload. The cardiac, the preload will reduce, hence the cardiac output also reduce, because the cardiac output follows the Starling law, right? Nanti saya cerita. And because of that, body try to maintain but increase systemic vascular resistance, and the perfusion will be low because of the reduction of the volume. How about the cardiogenic shock? Cardiogenic shock is because of the failure of the pump. So contraction will be low, the preload will be high, as we are also try to maintain about the reduction of cardiac output. The perfusion will be low because of the reduction of contraction. How about the distributive? Because of reduction of SVR, preload will be reduced. Body try to compensate by increase of cardiac output. The afterload will be reduced. That's why the BP will be low, and the perfusion will be either maintained or increased. The obstructive is because of the problem to 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 pump the blood out. This is because of tension in pneumothorax, tamponade or pulmonary embolism. The preload will be high. Cardiac output will be low because of the problem of the contraction of the heart. SVR will be normal or reduced, and the perfusion will be reduced. The fluid resuscitation is based on the Frank-Starling law, which by it stated that the stroke volume of the left ventricle will increase as the left ventricle volume increases due to myocyte stretch, causing more forceful systolic contraction. It is up until 2.2 micromole of the diameter of the myocytes. So after than that, at first you can see over here, when there is a more fluid given, there will be increase of the inotropic and reduce afterload. This is when there is a reduce of the stroke volume, there will be reduction of the afterload and increase of afterload and reduce inotropic support. So when we give fluid based on the Starling law says there is when there is increase of stroke volume, increase in cardiac output, right? So at first there will be a fluid responsiveness. That's why in over here we give 30 ml per kilo of fluid. So up until 30 ml, there is no more response to the fluid anymore, because the myocyte stretch at the maximum level 2.2 micromole of diameter already. So when we give more fluid during non-responsive part, the fluid will be shifted in the peripherous tissue. Example of our lung causing pulmonary edema. Okay, so if you come into the ICU during the fluid responsiveness, this is the arterial wave line. So the line will be upward and downward like this, showing there is a fluid responsiveness of a patient graph. And when there is no more fluid responsiveness, the graph of the outline will be plateau like this. Okay. So if you have a patient of 55 years old lady with CKD came to you with a septic shock secondary to CRBSI, will you give fluid resuscitation? They say this patient has 500 mils of fluid restriction. Do you give uh, fluid resuscitation for this patient? The answer is yes. Because why? The initial presentation of the patient, there is a vasodilatation. You need to resuscitate the patient up until patient is already optimized, and then later on, we stabilize based on the inotropic support, based on the antibiotic and stuff, and later on we evacuate the fluid back using, if this patient in CKD needs for dialysis later. So this phase is needed. No matter patient has a CKD stage 5 with fluid resuscitation, we need to give fluid. If the fluid, maybe if we initial fluid is 30 mils in a normal patient, but then in CKD patient, we might give around first small challenges of fluid 250 to 500 and look at the hemodynamic indexes of the patient. Okay. So most patients need no more than 3 liters per kilo of IV fluid, and this is to treat relative volume depletion due to vasodilation in sepsis, and it is to be completed within 3 hours. Okay, so so it is consistent with recent early go directive therapy (EGDT) studies based on ARISE, PROMISE, and PROCESS, showing no additional benefit for protocolized care as described as river. So no more, we no need to give more than 30 mils per kilo. After that, we need to check the dynamic status of the patient. So which type of fluid we give? We use crystalloid. Either normal saline, balanced solution, Hartmann, or plasma light. However, in sepsis, balanced solutions compared to normal saline are associated with improved mortality in sepsis admitted to ICU as compared, because why? There will be increment of AKI in the usage of too much of normal saline. So when to consider crystalloid? When there is a refractory hypotension, and we can consider usage of albumin. So because albumin is more safer as compared with others. So based on, but the study from safe trial show no difference between the normal saline and albumin in ICU patient overall. However, in RBO study also showing no difference in mortality. However, in RBO study, they said they will increase in the hemodynamic indices, meaning if we give albumin to the patient with in septic shock, there will be improvement of the BP heart rate to the patient. So better to give albumin as compared with others. So we must avoid stash in patient with septic shock. So when to give antibiotic? So antibiotic, as you guys read just now, administer broad spectrum antibiotic. We must administer immediately after the blood culture taken. So we must give ideally within 1 hour, and if the sepsis is possible, administer antimicrobial immediately, ideally within 1 hour of recognition. So kalau shock to absent tapi sepsis is possible, we must rapidly assess and administer within 3 hours if the concern of infection persists. So the blood pressure target. So as you can see before, the most important thing in measuring blood pressure is MAP. So mean MAP is a critical hemodynamic factor because it plays a role to measurement of good proportion to the organs. So our organs is trying to maintain its own mean arterial pressure by having its auto-regulation, meaning if there is reduced in the MAP, the vessel try to vasoconstrict to maintain its MAP up until certain level. Okay, so in a septic shock, the blood pressure target is more than 65 millimeter mercury. So how about the vasopressors? So the vasopressors, first of all, the vasopressors, first line after the patient is unable to maintain the MAP more than 65 despite fluid resuscitation is noradrenaline. Secondly, we add vasopressin. Thirdly, we add epinephrine or adrenaline. For other than that, we can also on dobutamine in cardiac problem. And also they are against use of terlipressin and levosimendan. The newer study, there is early adjunct of methylene blue in patient with septic shock. So over here, what I want to say to you, first line is noradrenaline, second line is vasopressin, third line is adrenaline. However, now in this study produced in the critical care, after the noradrenaline and also vasopressin, there is a use of methylene blue in the patient. Okay, this is the methylene blue that given in our ICU. The dose is 1 gram per kilogram, diluted in 500 ml of normal saline given over 6 hours. So studies have suggested that methylene blue is instrumental in inhibition of nitric oxide. So what I mentioned before, septic shock is because of the production of vasomediators, which is nitric oxide, causing the vasodilatation. So if we inhibit the nitric oxide, it will result in more controlled BP. Okay, this is among the last slides. So very important, we need to resuscitate the patient, early administration of appropriate antibiotic following the blood cultures, early source removal as soon as possible, judicious fluid resuscitation, avoiding excess of fluid based on study law. If we give more than 30 ml, we need to consider with monitoring. For example, we need to check whether the volume status is enough or not based on the cardiac output monitoring or using the echo. So using of noradrenaline for refractory hypotension, inotropic for septic shock, septic cardiomyopathy, therapies for refractory hypotension in which I'm not touching here, and other experimental and rescue therapies and ongoing support care and monitoring, best to be admitted in ICU. Okay. Summary, sepsis is a dangerous state of disease. If it is left untreated, mortality can be very high up until